Evening, good afternoon. This is Dr. Garais, and I'm your host today for BIO111, that's Anatomy and Physiology 1, and we're doing chapter 12 today, and that's sensory. So you have two types of senses, your general, which is general, and I want you to think more like skin. Everything that relates to the outside, because that's what your sensory does. The function of your sensory is just to relay data and energy information from the outside world to your brain, which will process it. Now, your special senses, those are things that are attached to your head, like vision, hearing, olfactory, which is smell, and gustatory, which is taste. And like I just said, the function of a receptor, which is part of your sensory system, is it is just a collector of data from external energy. So, for example, your eyes don't do any seeing. It's your brain that does the seeing and does the interpretation. It is your eyes that gathers light rays or light energy. Your ears gather sound waves, nose, they gather chemicals in the air so you can smell, and your mouth, it gathers chemicals in the food that you eat and drink. So what are the types of receptors? You have chemo, pain, thermal, mechano, and photo. Chemo responds to chemicals like your smell and your taste. Pain, of course, all over. They respond to any damage. They respond. Now, the beauty about pain is that it tells you where there's something wrong so you can go deal with it. And that's a pain receptor, also known as a nociceptor. Thermoreceptors, think temperature, tells you if you're hot or cold. Mechanoreceptors. Now, the big thing about mechanoreceptors is about mechanical forces. Think about blood pressure, number one, and touching or stretching. So blood pressure, of course, your body has to maintain a normal blood pressure. So if there's not enough distortion of the mechanical forces upon your arteries, then your blood pressure will decrease. If there's a lot of force, the blood pressure will increase. Now, stretch receptors, we're going to talk more about stretch receptors, or the mechanical receptor known as your stretch receptor, when we talk about reflexes, like your patellar knee reflex. And photoreceptors, those are your retina, which respond to light energy entering your eye. Sensation versus perception. Sensation is awareness of a sensory event. Like you know what's going on, like pain. I feel it. It's right here in my left knee. But the perception is like your brain interpretation of it. So I feel pain in my left knee. My perception is it's okay, and I kind of understand that it's most probably a flare-up in my osteoarthritis. Projection, sensation, perception, very good to know. Projection, nice to know. Sensory adaptation. That's your body's ability to start ignoring a sensory signal. So if a sensory signal is continuous, like sitting on this chair, the second I mentioned it, then you realize, oh, this is not the best chair in the world. That's sensory adaptation. Like you'll ignore it for the most part unless you're reminded of it again. You have three types of general senses: exteroceptive, interoceptive, and proprioceptive. External, I want you to think external. Internal, think blood pressure. And of course, proprioception, think about position sense. Free nerve endings, tactile, Pacinian. Remember, Meissner's fine touch, and Pacinian deep touch. And we already learned this from the chapter that we went over, skin. Warmth and cold, that's temperature, also known as thermoreceptors. And warmth and cold, if they're extreme, they'll now start activating pain receptors or nociceptors. Because you know, if something's too cold or something's too hot, it's going to be painful. Okay. Now, Pain receptors have very little adaptation. Therefore, I pinch you. While I'm pinching you, you'll feel the pain. As I stop, you won't feel the pain. Visceral pain or referred pain, that means the pain is coming from another part of your body. For example, we talked about flank pain. The flank pain, which is on the sides, which is in your lumbar anterior region of your abdomen, is actually pain that originates from your kidneys, which is located in your back or behind you. And the reason why referred pain happens is because there's a common nerve pathway. The other example that we talked about is acute myocardial infarction or heart attacks. You feel the squeezing of your chest, but it then radiates down here to your arm, and then can even radiate up here to your neck and shoulder. We also talked about appendix. You can have rebound tenderness. That means if I press on here on this side and then pull my hand off of it, the area of your appendix will start to hurt. Oh, excuse me. Sorry, I had to get that out. Pain inhibiting substances, enkephalin, serotonin, and endorphins. And we also link this to, especially the serotonins, linked to major depressive disorder. Proprioceptors, we already talked about Pacini and Meissner's corpuscles. Let's talk about the Golgi tendon organ. Those are the strut receptors in your tendons. So when you, right before you move, your tendons start feeling some tension, start feeling a little bit stretched because you're about to move, you're about to go somewhere. And that will stimulate reflexes that will, help you move and help maintain posture. Here's your muscle. Here's your tendon. Visceral. I want you to think of what digestive system. It's how we feel, how you, when you've eaten too much, you feel the distension or you feel the gas pain. Special senses are special senses in your head. Smell is olfactory, taste is gustatory, hearing in equilibrium because of your cranial nerve 8, that's your inner ear. Right, so you not only hear, you have balance, and it's combined special sense. And of course, last but not least, vision. It's your ability to see things. Olfactory, they are hair cells. You can locate, see here, above your turbinates, right here in your nasal cavity. You can also see the thinness of your cribriform plate, which is this is part of your skull. You can see how drugs and things can easily go in and out of there. Taste buds. They are also chemoreceptors, just like your nose olfactory receptors. They both require an aqueous environment. That means it's got to be a little bit moist. Right? That's why you have a nice mucosal lining that keeps that. And these two, the gustatory, which is taste, and your olfactory, they go together. And remember the analogy, the sinusitis, upper respiratory tract infection, cold analogy that I made. When we talked about how you try to eat your favorite foods when you're sick, and it shouldn't go very well because you need your olfactory to smell the food as you're tasting it as well. You have sweet, sour, salty, bitter, and umami. Umami is located in the center of your tongue, bitter in the back part of your tongue. That's the receptors, sense bitter. And sweet and salty are near the tip of your tongue, and they go together, and sour is along the sides of your tongue. Because if you look at your tongue, you can see there's different areas, different sections. See this different section here versus here versus here versus here. Here, let's go through the picture of the ear. Your auricle, also known as your pinna, is some textbooks consider it a vestigial organ. You don't really need it because it doesn't really trap sound waves. But what traps sound waves definitely is your external acoustic meatus, which is of course your ear canal. Your ear canal is connected to your tympanic membrane, also known as your eardrum. So sound waves travel through here. Let me see if. Oh. So, all right, sound waves. Nah, that's not gonna do it. Sound waves pass through here. Let me switch it back to. Sound waves travel through here in your external acoustic meatus. It vibrates the tympanic membrane, then vibrates the three smallest bones in your body, your malleus, incus, and stapes, also known as your ossicles. Then the ossicles will vibrate this oval window. Then it goes into this tubing here called your cochlea, where there's water and hair cells. Well, the water, also known as endolymph, starts moving when all of this started moving. And then depending on the different types of sound, it'll send a different signal to your cranial nerve 8, which is your vestibulocochlear nerve, cranial nerve number 8. Cranial nerve number 8, the cochlear part is the hearing part, and then you have the vestibular part here, which connects into your semicircular canals. Semicircular canals also have water with air in it, hair cells, right? When the water moves around, depending on if you tilt your head or your body to the left, right, up and down, your semicircular canals dictate, whether you are dizzy or not, whether you know which way is up or down. Eustachian tube, that's this tube right here. It connects your inner ear to your nasopharynx. Bony labyrinth, membranous labyrinth. There's inside the inner ear, there's a lot of in the cochlea, there's a lot of rooms and chambers in there. And the fluid that shakes the hair cells in there is called endolymph. So cochlea, think hearing, semicircular canals, think what? Equilibrium. Yeah. Oh. Oval window, round window, we already talked about those. Cochlea, hearing. Cochlear branch of the cranial nerve 8. This is what goes. And remember, thalamus is the thing of is the gate. Remember that gate? And the auditory complex cortex is in your temporal lobe of your cerebral. Otoliths are these little rocks that are inside your semicircular canals that will tell you what. Are you up, down, left, or right? Here's a typical hair cell lined in, and depending on the direction of it vibrates, it tells you, in this case here, whether you're going to be dizzy or not. Muscle orbicularis oculi, levator palpebrae. You have your extraocular muscles. That's this stuff here that control, which direction your eyeball goes into. Lacrimal gland. And it has a connection to your lacrimal duct, lacrimal sac, all the way into your nostrils. That's why you get a snot bubble when you cry. Superior, inferior, medial, and lateral rectus, and your superior and inferior obliques. That is here on the muscles or the rectus or the straight muscles that control your eye. The outer layer is fibrous, it's tough. We already learned that from the cornea. Middle layer is vascular, has a lot of arteries and veins. But the inner layer, that's the most important to us with the eye, that is the nervous layer. And you can see the nervous layer all the way deep inside here, and that's called your retina. There's a point on your retina here where you have your fovea centralis, which is the most concentrated area of rods and cones. And then you have an area that has no rods and cones, and this is your blind spot right here. Your blind spot is also called your optic disc. Then all of it is a confluence that goes into your optic nerve, which is your cranial nerve, Roman numeral 2. Cornea, of course, non-vascular covering of your eye that's on the outside. All of these things that we're now about to talk about, we're going to talk about how light gets refracted. And refraction is the bending of light. And your eyeball, as a machine, it bends light to the back part of your retina. Front part of your eye is made out of water. There's a water-like substance here in the anterior chamber, and in the posterior chamber, it is vitreous humor, which is more of a jelly. So in the front, more like water. In the back, more like jelly. Iris controls the amount of light entering your eye. Pupil is the actual opening, right? Aqueous and humor is the anterior portion, and the vitreous is the vitreous humor is the posterior portion. We mentioned fovea centralis and optic disc. Optic disc, blind spot. Fovea centralis, sharpest vision. Example here, we can diagnose hypertension, we can diagnose diabetes. They'll be like, if my patient's diabetic, you got these things called cottonwool spots. Vision doesn't look like this. Remember we mentioned in class. The light rays have, like, there's no image here in the inside of your eye. It's just that this diagram is showing where the light rays are going to end up. And in good normal vision, it should end up right on the retina. Nearsightedness, it'll be like over here. Farsightedness, the vision will end up over here. And that's why you have blurry vision when you have both nearsighted and farsighted patients. Rods for evening, cones for day. You also have pigments that absorb this light and get decomposed. So rods, of course, has rhodopsin, and cones have iodopsins. You have erythrolabe, chlorolabe, and cyanolabe, or labe. I'm not quite sure how to pronounce it. But of course, you have three kinds of cones. One's red, one's blue, one's touchdown. This is the reason why you have to have both eyes moving at the same way, so you can see three-dimensional objects. Here's also the optic chiasm, where the fibers cross. And that is chapter, that's chapter 12. Thanks for playing.